morning, everyone, and welcome to today's webinar hosted by PYA, COVID-19 Waivers, What Providers Can and Can't Do. PYA is a leading professional services firm providing expertise in healthcare, tax, management consulting, and audit and assurance. We are pleased to offer you our thought leadership on this important topic. All attendees have been placed in listen-only mode. You may submit written questions using the questions pane of the control panel. Our presenters will address as many questions as possible during the Q&A session at the end of the webinar. If we cannot answer all questions due to time limitations, we will supplement the written transcript with our written responses. Please be aware, with more people using online platforms, outages can occur. Should the webinar be paused, we will work to restore it as quickly as possible, and all of our webinars are recorded and released after the event. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Laura, and good morning, everyone. This is Martie Ross, speaking with you today from my home office here in Kansas City, joined with my colleague, Kathy Reep, who is coming from her home office in Orlando, Florida. Kathy, really glad you're able to join us today. Kathy is formerly the Vice President of Finance with the Florida Hospital Association, and in her 4 decades in healthcare, she has seen a hurricane or two, and thus has intimate knowledge and experience working with the Section 1135 emergency waivers. So after doing some introduction regarding the waivers in terms of the legislative authority for the Secretary to take action, we'll do an introduction to the initial blanket waivers that CMS has published. Then Kathy's going to dive more into the opportunity for individual states to pursue waivers. Then finally, we'll discuss how individual providers can avail themselves of this process. And then we intend to leave as much time as possible for question and answer. So let's just jump right in to our substance here. Well, actually, let's go back a bit. We're not one of the 1135 waivers was a new authority that Congress gave HHS as part of the original COVID-19 response legislation. That was the expansion of the Medicare Telehealth Waiver. Specifically, Congress authorized Medicare to lift the geographic and location restrictions for Medicare reimbursement. We addressed that subject in our webinar on Monday, and it is now available on demand on our website. You see the link here. Yesterday, in a national telephone conference, CMS Administrator Seema Verma announced that there would be additional guidance coming forward on the telehealth waiver and its application. It was in the context of hopefully by the end of the week, but as soon as that information becomes available, we'll be sure to get it to you. The one bit of good news that we can report here is that you're all familiar now that there's been agreement reached on the CARES Act. And although there's not been a public release of the actual language of the agreement, we do know in the original proposed legislation, it did include the expansion of telehealth benefit to rural health clinics and federally qualified health centers. So that's one small update we can provide since the webinar on Monday. So with that, we're going to focus on the balance of the 1135 waivers, starting again with that legislative authority. And it's a series of events that have to occur before CMS begins publishing the actual waivers. First, we have to have the president declare an emergency under the Stafford Act or the National Emergencies Act. We know that occurred on March 13. And then the Secretary of Health and Human Services has to declare a public health emergency. That happened way back on January 31st. So once those two events occur, under Section 1135 of the Social Security Act, the HHS administrator then can exercise waiver authority to with regard to very specific list of Medicare and Medicaid program requirements. And then in fact, Secretary Azar took that action also on March 13th, in most part authorizing the Center for Medicare and Medicaid Services to both publish blanket waivers that apply across the board to all impacted Medicare and Medicaid providers, but also then to have the authority to issue individual waivers based on requests from states as well as individual providers. Each waiver that is issued remains in effect for 60 days, although they can be renewed, but they terminate automatically at the end of the emergency. There may be provision for some very short wrap-up period, but as the most part, keep in mind as we talk through these requirements and these opportunities, they all terminate when the emergency is lifted. Also keep in mind, these are federal requirements only. There is no authority under Section 1135 for the Secretary to waive any state law requirement. That all has to be accomplished by individual action on the part of state governors. So be sure you're following closely your Office of the Governor website to see the publication of different authorities impacting state programs. As I mentioned previously, the authority under Section 1135 to issue formal waivers is limited to certain program requirements. It is not an across the board, however you feel like doing it, authority to CMS. There are in fact these 10 areas in which CMS or other HHS agencies can take action under a Section 1135. And that comes with a small asterisk. As you note, item number 10 here on the slide refers to the 3-day prior hospital stay. That is actually not an 1135 waiver, it's a 1812 waiver, but who's going to argue over a few sections? But as you see, these are limited in scope, primarily go to administrative tasks that providers have to accomplish, and it is very specific in where we can go to impact change. In addition to this, there is guidance that CMS issued back in March of 2019, which define how the agency will exercise its authority. So we have to keep that in mind as well as we walk through what's happening now with the 1135 waivers. I'm going to turn this over here now to Kathy, since she has greater familiarity with the requirements with regard to claim submission when you're acting under an 1135 waiver. Kathy?
Thanks, Marty. Good morning to everybody. Glad you're able to participate on the webinar this morning. Just a little bit from a billing perspective, because of some of the waivers that have been issued, in order to get your claim to bypass current edits, and we'll talk about some of these a little bit later, but some of the edits that are in the Medicare payment systems. Once a waiver has been approved or issued, then there are certain codes that you have to put on your claims in order to bypass edits. For institutional claims, you're going to use the DR condition code. It's just basically saying that it is disaster related. You do not use a DR code currently on claims submitted for Part B. You would submit the CR modifier for professional claims. However, there was on Monday a meeting of the National Uniform Billing Committee. The National Uniform Billing Committee has approved that the condition code DR could be used on Part B claims once that has been adopted by the National Uniform Claims Committee. And I believe they are meeting very quickly to move forward with adoption of that code, so that they would also be, you would also be able to put DR on a Part B non-institutional claim. I think the thing to remember on these codes is that the use of the DR or the CR really goes back to the designation of the public health emergency by Health and Human Services. And unless there is a waiver in place for particular items with in your state or a blanket waiver nationally, then you cannot use the DR or CR codes. You must have the authorizations in place first. Martie?
And just one note is, as we discussed in the telehealth webinar on Monday, one does not utilize these codes or condition codes or modifiers on new telehealth claims. CMS is very explicit on that point in its publication of the guidance with regard to the telehealth waiver. Oops, sorry, went a page too far there. Of course, while 1135 is the formal process for waiving regulatory requirements during an emergency, there are other options available to the federal agencies to provide regulatory relief for providers during a national emergency. There is a process by which they can informally waive procedural norms that are part of their own guidance or policy. So CMS can, as you know, there are miles and miles of manuals under which CMS operates and how it directs the activities of its Medicare administrative contractors. There is authority there, so long as that procedure isn't, in fact, a reflection of a regulatory or statutory mandate. CMS has flexibility there, and in fact, it has begun to issue guidance to the MACs, specifically related to different guidance-based requirements. Additionally, the agencies can exercise enforcement discretion. And where we saw this week was CMS's action with regard to survey inspection, that they announced they would be following a new streamlined process for hospital and skilled nursing surveys. And in fact, those surveys would be limited to immediate jeopardy inspections based on complaints, as well as very targeted infection control inspections. They would not engage in regular standards surveys or re-inspections. The action that CMS took in this regard is consistent with what we're seeing from the accreditation agencies, such as Joint Commission, and their decision also during the national emergency not to pursue surveys. But again, that's an exercise of agency discretion, and I believe we'll see more and more coming out from different agencies under this discretionary action as more specific obstacles are being identified within the emergency circumstances. And finally, of course, the agency retained the ability to publish interim final rules with comment period. The Administrative Procedure Act generally requires an agency to publish a proposed rule, allow a specified period of time for comment, review of that comment, and then publication of final rule. But in exigent circumstances, an agency can issue an interim final rule, foregoing the comment period upfront, but allowing for the comment period subsequent to the publication of the rule. Again, on the webinar yesterday, Administrator Verma indicated that it is likely that we'll see these interim rules coming out of CMS. So where they don't have the authority under 1135, they potentially can then change the regulatory structure through this interim final rule process. Again, our job here is to keep on top of that, make sure that we're pushing that information out to you as quickly and as relevantly as possible. So with that background, let's talk about the blanket waivers that CMS has issued thus far. If you want to get to the core documents here, there are 3 that pertain to the blanket waivers. The first was the March 13th emergency declaration of the healthcare waivers, the provider fact sheet, which came out at the same time that Secretary Azar signed the actual waiver authority. So this is CMS explaining how it's going to, the first round of its implementation under the waivers. Then there's a March 18th MLN Matters Special Edition article. It is probably the authoritative piece right now if you want to turn to that document. Certainly what we use to build this presentation for you today. Complementing that, the Office of Civil Rights issued its HIPAA bulletin, which talks about the particular waivers of HIPAA requirements during the emergency. Again, we have links to these documents available to you on the PYA COVID-19 hub. So what we know in the blanket waivers, they break down into 5 categories. And we're going to talk about these waivers within this categorization about hospital capacity, workforce expansion, eliminating red tape and administrative requirements, and then specifically what has been done under HIPAA and EMTALA requirements. Very important to understand the limitations on the waiver authority, especially in the context of HIPAA and EMTALA. And as Kathy will talk about, how that presents opportunity to pursue requests for individual waivers that go beyond those relatively limited waivers that are within the under the blanket. So starting with hospital capacity in 3 particular areas. Under skilled nursing facilities, and probably the most significant of all the blanket waivers, is CMS permitting the transfer of a patient to a skilled nursing facility without a prior 3-day qualifying hospital stay. So this allows hospitals to effectively clear out less acute patients, shall we say, and get them to a skilled nursing facility where they can receive an appropriate level of care. We don't have to go through the 3 days before you can transfer to a SNF and have that then SNF stay qualify for reimbursement. So, of course, this is creating its own set of capacity issues now with the skilled nursing facilities as they're seeing increased volume. So certainly encourage hospitals to be working with those post-acute partners, open very clear lines of communication, since we're going to see much more rapid transfer of patients in those facilities. Second area for expanding hospital capacity was the utilization of hospital distinct part units. The rules as they stood before the waiver were very specific on where patients could be bedded within a hospital that had distinct part units. So first of all, you are able to place acute patients in distinct part units, such as psychiatric units or inpatient rehab units, provided that you can provide appropriate care to those acute care patients in those units. So as you are increasing the need for bed capacity, you've run out of acute beds, it allows you to effectively invade these units to provide acute care services. On the flip side, then, is also true. If you have patients that are in distinct part units, it becomes necessary to transfer them to acute beds. You may do so again only so long as you can continue to provide the appropriate level of care, rehabilitative care, psychiatric care in those acute care beds. CMS also clarifies here that you would continue to bill for those services under either the psychiatric or rehab IPPS, even though the patient is then actually in an acute care unit. Finally,
Martie,
the third, please jump in.
Yes, for the patients who are acute that you put in distinct part, your first bullet, you do continue to bill those patients under the inpatient prospective payment system, not the payment system for the unit where they've been placed.
Excellent. Third opportunity for increasing hospital capacity is looking to our critical access hospitals. As you know, the conditions of participation for those hospitals require that they limit their inpatient beds to 25, that they are restricted to have admissions that do not exceed 96 hours. Both of those limitations have been lifted, and we're already hearing reports of several critical access hospitals that are finding themselves bumping up against those units, against those limitations. Keep in mind, again, you can only take this action and move these patients, manage capacity in response to COVID-19. So you'll have to make sure you're within that appropriate context. Now that's Medicare's world, what they're doing. What do we know about the commercial payers in this context? The American Health Insurance Plan Board of Directors a couple of days ago released a statement with regard to hospital capacity issues. You'll see here the quoted language from those statements, first making clear that yes, it's permissible to move patients into skilled nursing facilities. The expectation from commercial plans is that both the hospital and the skilled nursing facility will provide notice to the plan the next business day after that transfer occurs. More broadly on other hospital capacity issues, you see more the board of directors encouraging and reinforcing action by other commercial plans that are expanding out to mirror what Medicare has done. Again, don't worry about taking a snapshot of your computer right now. The slides will be available on our website as well as the recorded transcript from this presentation. But this is positive news. Certainly if AHIP is taking this lead, of course, the AHIP board of directors is very representative of the large commercial payers. So we're seeing some good movement here. But otherwise, the fact Medicare has issued the waivers, we said before, doesn't change anything except Medicare rules, and we just hope that commercial payers follow suit so we have consistency, continuity as we adjust our business plans, adjust our procedures to reflect the blanket waivers. So I said, second category of waivers relate to workforce. Importantly, CMS has a broad requirement across all of its programs that an individual furnishing services to be reimbursed under Medicare must be appropriately licensed in the state in which they are furnishing those services. The blanket waiver now allows the provision of services by an individual in the state in which they are not licensed, but only again for the purpose of providing services that relate to the emergency. Keep in mind, however, and this is the critical exception, is nearly every state board of medicine requires that an individual furnishing services to a resident of that state be licensed in that state. And so now in follow to the blanket waiver, we're seeing a number of governors now issuing orders that permit unlicensed individuals to come to the state and furnish services. For example, here in Kansas on Sunday, Governor Kelly issued an order, of course, waiving the licensure requirement, but requiring physicians to provide written notice to the State Board of Healing Arts that they would be providing services in the state of Kansas. So all of these orders from the states are going to have some variation in them as well. Be sure you're aware of these. The general consensus is that this includes telehealth, that it would allow an individual to provide telehealth services to patients in other states within the concept of the telehealth waiver. Though CMS has not specifically addressed that issue, there is some inconsistent prior guidance on this point, but it appears now that the consensus is around that this applies also to telehealth. But remember, we've got to worry about the state licensure requirements in this context. Second, workforce expansion action taken by CMS under the blanket waivers concerns provider enrollment. Oh, Kathy, did you have a comment? Sorry.
No.
Please. Yes?
No.
Okay, sorry everyone. Provider enrollment, CMS is simplifying the provider enrollment process. They have in fact now published on their website toll-free hotlines where you're able to enroll quickly and receive, sorry, just a second there, go back to the original slide, and receive your temporary enrollment. They're also waiving fingerprint requirements and site visits, and they're postponing revalidation actions. Again, their goal is to get as many people into the system providing services as possible. CMS, with respect to other, those apply, excuse me, to providers and non-physician practitioners. For other providers, CMS is also expediting the process, promising to act within 7 days of a clean online submission, 14 days for a clean paper submission of application, and are also waiving some of those background requirements as well with regard to provider enrollment. Third category are administrative requirements, and these sort of are all across the board, but most importantly on the area of Medicare appeals. We're extending time periods in which to file those appeals. They're waiving timeliness in requests for information. They're processing appeals, so allowing appeal to go forward even if you do not have the appointment of representation forms completed yet. And they're also they're going to permit requests for appeal even if they do not meet all the required elements. So a great deal of grace being exercised by CMS here with regard to the appeals process. For home health agencies, They are relieving the timeframes in which OASIS transmissions must be completed, and they are also giving the Medicare administrative contractors the authority to extend auto cancellation dates from the date of request for anticipated payment. Skilled nursing facilities, they are providing extended benefits for individuals who have exhausted coverage in certain circumstances without having to start a new benefit period, which becomes critical in terms of your total SNF day allowance. And they also are relieving the timeframes for MDS assessments and transmission. For our durable medical equipment providers, they have issued the blanket waiver that permits the replacement of lost DME if the beneficiary is unable to access or they've lost their equipment due to the emergency, that can be replaced without the requirements of physician visit, physician authorization, and the like. And finally, with respect to Part B drugs, there's expanded coverage for replacement prescriptions in those instances where medications are either unusable or unavailable due to the emergency. So very specific administrative requirements. These are very similar to what one has seen through the hurricane emergencies as CMS has issued those blanket waivers. Fourth category on HIPAA. And most important thing to keep in mind here is this is really, really narrow. As you see, there are only 5 specific HIPAA requirements where Office of Civil Rights, the agency that enforces the HIPAA privacy rule, they have waived penalties associated with non-compliance in 5 specific areas. So it includes, the having to first receive the patient's permission to speak with friends or family members, honoring a request to opt out of a facility directory, the requirement of distributing the notices of privacy practices as patients arrive at the facility, patient's right to request privacy restrictions, and a patient's right to request confidentiality communications. OCR will not pursue penalties against hospitals for non-compliance with those provisions, but only, underline that a couple of times, only when the hospital has instituted its disaster protocol, and only for a period of 72 hours following the implementation of that protocol. So keep in mind, it's only for hospitals, it's only very specific provisions of HIPAA, and it's only going to remain in effect for 72 hours following the implementation of a disaster protocol. Again, Kathy's going to talk about the opportunity to seek expanded waivers under HIPAA. Finally, let's talk about EMTALA. Prior to the National Emergency Declaration, so pre-waiver, on March 9, CMS published guidance on EMTALA as it applies to COVID-19. Noted that it is appropriate for a hospital to identify an alternative screening site on the hospital's campus, but required that a qualified clinician be present to redirect anyone who actually arrived at the emergency department. Would have to escort them, determine appropriate and escort them to that alternative facility. With regard to off-campus alternative screening sites, CMS noted that it is appropriate to encourage the public to go to these sites, but made clear that you could not redirect a patient from the emergency department once they arrive to go to an off-campus facility. Now, with the waiver, CMS expands that authority. So there are now more options available to a hospital under with regard to managing this patient flow into the ED without risking EMTALA liability. So it is now appropriate to relocate a patient to an off-campus site. So what you could previously do pre-waiver to relocate a patient to an on-campus site, you can now also do with regard to an off-campus site, but only if you're taking that action consistent with the state emergency preparedness. The other EMTALA exception under the waivers regards transfers and permitting facilities that do not have capacity or capabilities to manage COVID-19 patients to transfer them while they're still under the EMTALA definition of unstable. As you know, under EMTALA, there's an obligation on the facility transferring the patient to the receiving facility to stabilize that patient prior to transfer. Always been an interesting area of interpretation on what's stable for transfer. But in this case, CMS has waived that particular requirement to ensure that we have smooth and efficient transfer of patients, again, from facilities that either are overwhelmed or don't have the capacity for appropriate isolation of COVID-19 patients. So that is our realm of the blanket waivers. I think you're probably appreciating, as we did as we delved into these, they are relatively narrow. And these are blanket waivers that are well tested by CMS. Most have previously been issued under either the hurricane, the flood, or the H1N1 emergency declarations. So that means there's a great deal of room here to pursue individual waiver requests from CMS, appreciating at the same time that CMS has already signaled that it's intending to expand those blanket waivers as it becomes more attuned to the needs of hospitals during the emergency period. So I'm going to turn this over to Kathy here to discuss individual waiver requests.
Thanks, Marty. In order to, whoops, one slide too many. Can we go back? Marty, I'll let you, okay, there we go. In order for an individual, in order to get additional waiver requests, you must submit a request to your regional office. We have a slide coming up that will give you the addresses for the various regional offices and what states apply to each. But you must submit a formal request. In the past, we have done very extensive letters that were really going through explaining why we needed each and every item that we were asking for. However, well, I guess it was on Sunday, CMS came forward with a template format that really was almost a checkbox. Gave a cover introduction saying this is why waivers are being requested, asked for fill in the blank information in terms of what organization or state is asking for the waivers, contact information, things like that. And then it proceeded to give a list of about 6 or 7 items that just said, here, do you want this, 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 and this? And it listed numerous items that you could then go in and check off saying, I want this. I think any provider probably would check off saying, I want all of these. But for instance, under Medicaid authorizations, it was to suspend the Medicaid prior authorization requirements. Also requiring fee-for-service providers to extend pre-existing authorizations for those who have already received them, to extend them for a longer time. Suspend the requirements under the PASSAR level 1 and 2 assessments for skilled nursing facilities. It was already mentioned, but the minimum data set authorizations for skilled nursing facilities and nursing homes, to suspend the requirements for that. So a number of items that were listed that CMS gave the opportunity to say, do you want this? And the thing that is important on these items is they are not automatic unless you submit this waiver request. There are some items that were on here. I'll give you an example under provider enrollment. Waive the requirements that physicians and other healthcare professionals be licensed in the state in which they're providing services, so long as they have equivalent licensing in another state. That is very important, and you need to make sure that it is clear that this is a waiver that has been approved for your state in order to operate under this. Another one that I just wanted to call your attention to that is under provider enrollment is a statement, waive the conditions of participation or conditions for coverage for existing providers for facilities for providing services in alternative settings, including using an unlicensed facility, if the provider's licensed facility has been evacuated. And that's where it ends with what CMS had you check off. In other words, in order to use alternative settings, including an unlicensed facility, your facility would have to have been evacuated. We are suggesting that if you are submitting CMS's standard waiver request, that you add to that the statement, or if additional space is needed, because many providers are hitting a point of capacity. They need to use additional space, even unlicensed facilities, but you have not evacuated your existing facility. So I think that's a clarification. To date, there have been 13 states that had waiver requests approved. Florida was the first, followed closely on its heels by Washington State, and then 11 additional waivers were approved early this week. The one thing that I again stress, many of these included similar items, but if you are doing waiver requests, it's good to make sure you look at others, making sure that they are inclusive of everything you could possibly ask for. There is also the ability, in order to get additional amendments under the state Medicaid program, but I wanted to focus, because of time, on some of the things that we are suggesting you make sure you include in your requests. The first one that I've mentioned under EMTALA, Martie discussed the EMTALA waiver that has been approved, but I also urge you to consider the request to CMS. Right now, there is a requirement to obtain special designations for qualified medical professionals who can perform medical screening exams. The requirements for that involve approval by the medical staff, by the governing body. If you're bringing in other individuals into your organization to help with the volume of patients, and we need to get these folks approved to do medical screening exams without having to go through a governing body requirement. Also, we need the ability to expand who we consider qualified medical professionals to include perhaps some licensure categories that are not typically approved within your organization or within your state. Martie mentioned that under the distinct part unit provision, you could put an acute care patient in a rehab unit. I want to make sure that you include in a waiver request that some of those things that you're required to do for rehab patients, you have a waiver not to do for acute care patients who are being housed on that unit. Obviously, no, these patients are not going to be able to participate in an intensive rehab program. There is no need for the pre-admission screening to make sure that they can tolerate intensive rehab screening. And obviously, they should be excluded from your patient assessment instrument and your rehab quality reporting. Just some provisions to make sure that you ask for to expand your ability to use the distinct part rehab unit to house acute care patients, and then don't get in trouble with having patients who did not meet rehab criteria. A couple people have made the comment that it's in a year, 2 years, when there are audits and reviews of claims that you submit during this time, it is so very important to make sure we have clearly documented what we are doing and why we are going beyond the norm. As an example, if you are housing an acute care patient in rehab or a rehab patient in acute care, you need to make sure that you are clearly documenting in their medical record why this is being done, the waiver was in place, etc., so that it is there for audit purposes in the future. From a physical environment perspective, we are suggesting a few additional items that you might want to include from a waiver perspective. To use non-hospital buildings to be used for patient care. There is the ability to use alternative locations, but so far CMS seems to be very focused on alternative healthcare locations. We've heard even in New York that we are looking at using the Javits Center for providing patient care. We need to make sure that it is clear that this is approved and that we can be billing for patients who were not housed in hospital locations. I mentioned earlier when we were talking about the DR condition code that there was some action by the National Uniform Billing Committee earlier this week related to billing requirements under COVID-19. And one thing that we did discuss was using non-hospital buildings or space for patient care. And how do you bill for that? Because we do know that there is a requirement under the Medicare system that the address where the service was provided needs to be a part of your PACOS file. You need to have submitted that information on an 855A and said, these are all of the addresses and locations where I provide outpatient services. What the National Uniform Billing Committee has recommended, and this notice is on their website, in order to meet patient needs, many hospitals and health systems have moved testing locations from hospitals to off-campus facilities such as parking lots, parks, football stadiums. In such cases, the NUBC recommends usage of the type of bill 013X, that's your outpatient claim, the main hospital address, and the national provider identifier. And then when paired with the DR condition code, that will allow the claim to bypass site of service restrictions. We have asked the payers to allow that bypass. And again, you would not be putting the physical address of where the service was provided if it was not on your PACOS file, but you would be merely using your hospital's physical address. We are also suggesting that you ask for the opportunity to use technology, video, things like that, and even some physical barriers to limit exposure to individuals within your organization. As an example, if you do not need multiple people in a room, is there a way to connect via audio for discussion for that patient's care? And obviously that issue that we've been dealing with, that we're starting to see many areas implement, and that is to be clear that you can provide exam and treatment of a patient who's in a vehicle as opposed to actually within your hospital. Next slide. Okay. Other waivers that you might want to consider. We currently have a restriction on infrequent use of verbal orders and that they must be authenticated within 48 hours. You might want to ask that that be waived because you might not get those verbal orders authenticated as quickly as you would expect to. And again, they might be used a lot more frequently than your current policies would allow. There is a current requirement that patients who are in the intensive care units who are restrained upon death of an individual, you would have by the close of the next business day, you would have to report that patient's death. We are asking or suggesting that you consider a request for a waiver that if the patient's death was not tied, that's a bad word, was not related to the use of the restraints, that not have to be reported as quickly. There be some leeway there. Asking for waiver of the completion of medical records within 30 days following discharge. Again, you might not have time to get this done if you consider how long this has been going on and the work volume that your HIM staff and your physicians are going through. There is a requirement now in order to use standing orders that they be reviewed and approved by the medical staff and the hospital nursing and pharmacy leadership. I don't know that you have time to do that. I think we need to be able to waive that provision for implementation of standing orders. Suggestion that I have heard from some other states, eliminating or waiving the requirement for physical signature of a patient or patient's representative on forms such as the important message from Medicare, the consent, various clinical documentation items. You don't want to be going back and forth with patients and staff and PINs. So if a patient can give verbal consent and then that be documented that the patient gave verbal consent, it's much better than passing things around from a PIN perspective. The last one here that I wanted to touch on this page related to your advanced directives. We are not asking that you, we are saying that you would still ask a patient if they have an advanced directive, if there's an advanced directive in place, but that hospitals be given, and nursing homes and hospices and everyone else, the requirement to provide information related to advanced directives be eliminated during this time period. It's really not something that you want to be raising. Yes, ask them if they have advanced directives, but do you have to go through the whole process of brochures and information explaining what is an advanced directive? The next slide, just a few more things that we wanted to touch on. Number one, waive timely filing. We have our 12-month period for timely filing. Right now, you might not be able to get all of your claims submitted, and we need that extended. We would also urge this as it relates to payers other than Medicare. And I say this as an example: when you have a requirement to bill within a certain period of time, systems aren't even necessarily ready in some states, in some areas, to get the correct condition codes and modifiers on the claims. The 60-day rule for processing overpayments, you have identified that there is an overpayment within your organization. It needs to be returned to the Medicare program. Because of cash flow issues, the time that it takes to process and the resources committed to that, if that 60-day rule could be waived for the period of this public health emergency. Very important that you ask for suspension of a lot of Medicare administrative contractor activities, things related to recovery auditors, audits of the S10 worksheet, the Medicare cost report, reviews of the 2 midnight rule, things like that. That needs to be lifted right now. We don't need that. I will tell you that I have seen that many contractors are moving forward with audits of the S10 worksheet. I don't think that's really appropriate. I actually even saw a MAC that earlier this week sent a satisfaction survey out. And I will tell you that was not the best thing right now. And I don't think their response level is going to be, in terms of the number of responses received, it's not going to be great. It's not a good time to send a survey like that. And finally on here, we wanted to suggest that for critical access hospitals, where there are payments that are owed related to prior year cost reports and final settlements, that there needs to be some flexibility for those providers because of cash flow crunch right now. Again, allow them a little additional time. With that, Marty? Oh, here are the addresses, I'm sorry, for the submitting your waiver requests, and then I will turn it to Marty.
The types of waivers that Kathy has been discussing as opportunities really would be applicable across the board within a state. And while most of the state waivers to this point have focused on Medicaid requirements, certainly it is advisable to broaden these to additional Medicare requirements under the waiver authority. And so both The state agencies can pursue these, state hospital associations, other provider organizations, using their voice through these waiver application processes are great opportunities. But we're going to focus here on individual provider requests for waivers, which is, let's focus particularly on the Stark waiver. Now, if you have read an article that says the Stark law has been waived pending the emergency, please do not take action based on that. It is, in fact, a much more ordered process. When Secretary Azar issued the order invoking the 1135 waivers, he authorized CMS to waive Stark law sanctions, but only in circumstances as the agency determines is appropriate. CMS has not issued any blanket waiver regarding the Stark law. Presumably, CMS, and in its prior guidance, CMS has indicated that it would review these requests on a case-by-case basis. And it is unlikely, though not unheard of, but unlikely we'll see a blanket Stark waiver. Instead, this is intended for case-by-case review. And in fact, in our research, as deep as we could dig, we could only find one example of an emergency Stark waiver that related to Hurricane Katrina back in 2005. So this is at least a rusty process for CMS as it starts looking at these specific requests for Stark waivers. But the fact that there have not been a lot before does not indicate there is not a need today. American Hospital Association last week sent a letter to CMS, OIG, Department of Justice, asking them to suspend enforcement of Stark and anti-kickback, given that would provide hospitals with a great deal of efficiency and flexibility as they meet the demands of this public health crisis. AHA also in that letter urged CMS to adopt an interim final rule that would accept from the definition of compensation arrangements any financial relationship into which a hospital entered into with a physician to secure necessary goods and services to respond to the public health crisis. To date, CMS has not responded, at least publicly, to the AHA's requests, but at least these issues have been placed on their radar screen. As we're talking with clients about the impact of the COVID-19 pandemic, we're beginning to hear more and more concern with regard to both relationships with employed physicians, hospital employed physicians, but also the status of independent physician practices. Those closely relate to the decision to cancel elective surgery. So you have many practices that are almost nearly idle as a result of that action. Obviously, that's going to place significant financial pressure on those practices. So we here on this slide identify a number of different circumstances that we believe a hospital would pursue a financial arrangement with a physician, but where there will be Stark considerations that need to be addressed, either by navigating carefully the existing Stark exceptions or in fact appealing to CMS for specific relief in a circumstance to provide a waiver of Stark enforcement activity. The other piece of this, although not specifically authorized in 1135, we have the question of the Civil Monetary Penalties Act and its prohibition on beneficiary inducements. We know that if you improperly offer anything of value to a beneficiary, that one would assume likely to influence their selection of a provider, that's exposing you to liability of $10,000 per prohibited inducement. But here there are legitimate needs to provide remuneration to patients relating to quarantine, for example. Are we going to provide housing or meals or other assistance to individuals in quarantine? And then similarly, as we expand telehealth capacity, we're going to need to meet the technology gap and maybe necessary to provide smartphones or tablets to patients that they can use telehealth, or provide monitoring devices as we discharge patients from hospitals. We can be able to monitor them appropriately to ensure their condition. Also providing personal assistance, sending those assistants out to assist patients with telehealth visits. All of these potentially bring into play the issue of beneficiary inducements, another area where CMS, if not necessarily exercising authority under 1135, could in fact exercise its discretionary enforcement authority. So opportunities there as well. So how do you make these individual waiver requests? It is a matter of submitting a written request to the appropriate CMS regional office. That slide previously that Kathy highlighted gave you the appropriate email address based on your state. CMS encourages you to copy the state survey agency when you submit these requests, that they are aware of the activity that you're pursuing. And there is no form, unlike for states where CMS has published its checkbox template for requesting Medicaid waivers. We do not have an equivalency for providers that are pursuing waivers around specific financial arrangements. But CMS has identified here that your waiver request should include certainly contact information, your Medicare provider number, but critically providing a brief summary of why you need the waiver, what's the scope of the issue, and what's impact it is having on your ability to respond to the emergency, or the long-term negative effects it potentially could have on your medical community, and then what specifically is your requested relief. One would think that a broad, please excuse any violation of the Stark Law is not going to be received very well, but instead providing a very specific, defined action you wish for CMS to take. CMS has said previously that it intends to act on emergency waiver requests within 2 to 3 days of receipt. That most likely will be pushed back given the volume that they're likely to receive, but in most instances, waiver requests are granted on a retroactive basis to the date of the request. So hopefully that would provide some relief there as well. So that's where we are today on Section 1135 waivers in terms of blanket waivers, in terms of opportunities for states to request specific waivers, both to the Medicaid program as well as other program requirements, the opportunities for individual providers to pursue waivers to insulate financial arrangements they believe necessary to enhance and even fuel their response to the COVID-19 emergency. We're not stopping in terms of trying to provide relevant information for you. Our next webinar is scheduled for tomorrow afternoon. This is a very less technical, much more practical approach to telehealth. We've been hearing from a lot of physician practices that have not previously stood up a telehealth capability. And so we want to provide some really practical, here's how to select technology, here's how to address processes, here's how to engage patients. That's our intention tomorrow. And then though we didn't even have time to create the slide, but Monday we'll be announcing a webinar for Monday to address the healthcare relevant provision of the CARES Act. That's that compromise legislation, a mere $2 trillion in relief related to the COVID emergency. In there, we know there's 130 billion tagged for hospitals. We know that there's over 300 billion in new SBA loans that can support independent physician practices and other providers. We're going to spend our weekend figuring out how those provisions work and provide you some really practical guidance on how you're going to be able to avail yourselves of those opportunities. So I've left a whopping 3 minutes for questions. I apologize for that, but there's just a lot of content here. Can open up the phone lines, but please, we have done our best to respond to comments, questions that we've received written. We should today post the Q&A responses related to the telehealth webinar. We'll do our best to turn this around as well. So Laura, I'm going to send it back over to you.
Thank you. We have time for just one question, and our first and only question will be, does the 3-day prior hospitalization waiver apply to hospital swing bed services?
This is Kathy. It is my understanding that there was a clarification issued, I believe it was Monday, that clarified that it did apply to swing beds. We will make sure that in the final Q&As that we post, we get you the actual link to that.
Thank you. And thanks to our presenters, Martie Ross and Kathy Reep. If you have any questions, their presentation and contact information will be emailed to you along with the recording of today's webinar. Also, if PYA can provide assistance, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.